Welcome to the Strokecast. A Generation X stroke survivor explores rehab, recovery, the frontiers of neuroscience, and how to peel a banana with one hand.
Hello, I'm Bill Monroe, and welcome to episode 40 of the Strokecast. Meet Dr. Kimberly Brown. And this week, you're definitely going to want to stick around to the end of the show because we have a special musical treat. But before we get to that treat, we do have a great conversation with Dr. Brown. Dr. Kimberly Brown is an ER physician. And as stroke survivors, these folks play an important part in our survival and rapid treatment, but we often don't think about them. See, we build ongoing clinical relationships with our neurologists, our physiatrists or rehab doctors, our OTs, PTs, rehab nurses, CNAs, and more, but not really the ER docs. When they see us, our brains are in full crisis and panic mode, our loved ones are terrified, and the doctors are just super busy making rapid assessments, decisions, and referrals to other specialties. By the time we get a chance to calm down and sort of assess our new landscape, they are long gone and have transitioned off our care team. That's one reason I really enjoyed talking with Kimberly. It was a chance to get some insight into a field and the mindset that I knew very little about. Plus, she's just awesome. Among the things I found interesting was how she talks about the impact of technology in medical education. Things like listening to a heart murmur on the computer during schoolwork and later tying that into the real world by listening to an actual patient. We also talk about the role of ER pharmacists, which is a role that I never even knew existed. The role of Methodist University Hospital has had in treating folks with the clot-busting drug TPA. And in 2014, they actually treated more folks with TPA than any other hospital in the world. And we talk about some of the challenges around public health. We do have some discussion of the politics of healthcare in this episode. Regardless of how you feel personally about the Affordable Care Act, the Americans with Disabilities Act, the future of Medicare and Medicaid, the political decisions around these programs will directly affect the lives of millions of stroke survivors and potential stroke survivors across the U.S. And it's important to be aware of what's going on and to express your views to your elected officials. Dr. Brown serves patients in the stroke belt of the U.S. This is the region of the country that, since the early 60s, has had significantly higher amounts of stroke patients and higher mortality from stroke than the rest of the country. It includes many of the states in the Southeast, including Tennessee, Virginia, Kentucky, North Carolina, South Carolina, Georgia, Alabama, Mississippi, Louisiana, and Arkansas. There are a number of reasons for this, including poverty in urban and rural communities, the challenges facing Appalachia, the opioid and meth crises, access to care, and other issues. It's not an easy problem to solve, but Dr. Brown does offer 5 steps to start with, including making sure that all patients have access to health coverage, decreasing food deserts, programs to incentivize physicians to go to underserved communities in both Appalachia and urban centers to ensure access to care. Make sure schools are good enough so that kids can read and understand important information about their health. And of course, medical professionals have to do a better job of educating patients about how their bodies work and what's going on with their body when they come in for healthcare. A couple more notes before we get started. We referenced the FAST signs for stroke. If you're not familiar with FAST, it refers to sort of the very basic symptoms that folks outside the hospital can use to recognize a stroke. They are face, arms, speech, and time. Facial droop can indicate a stroke. One-sided arm droop can indicate a stroke. Slurred speech or challenges speaking can indicate a stroke. And T means that it is time to call emergency services as soon as possible to get that patient to the ER. We also talk about sepsis, or about being septic. Sepsis can be the result of a body's attempt to fight an infection. Basically, the infection results in the body dumping an excess of chemicals into the bloodstream to try to fight the infection, but what actually happens is that it leads to inflammation in other organs. Sepsis can sometimes mirror the symptoms of a stroke, and like a stroke, it is another life-threatening condition. Fortunately, whether you come into the ER with sepsis or stroke, folks like Dr. Kimberly Brown are there to take care of you. Dr. Kimberly Brown is an emergency physician in Memphis, Tennessee. She's a native of Milwaukee, Wisconsin, and earned her undergraduate degree from Fisk University. Loving warmer weather, Dr. Brown earned her Master of Public Health degree from the University of Florida in Public Health Management and Policy. She attended Ross University School of Medicine and recently completed her emergency medicine residency as a member of the inaugural graduating class of the University of Tennessee Health Science Center in Memphis, Tennessee. Dr. Brown's clinical interests include neurologic emergencies, critical care, sepsis, and education. In her free time, she enjoys traveling, volunteering, watching too much reality TV, and trying new restaurants. Now, let's meet Dr. Brown. Kimberly, thank you so much for joining me on Strokecast this week.
Thanks for having me. I'm really excited.
It's great. I've talked to neurologists and other providers, but you're the first emergency department physician that I've had on the show. And that has got its own kind of amazing excitement in the specialty. I'm sure we'll get into some of that, but why did you want to become a doctor to begin with? And is that something you always wanted to do?
Yes, I am one of those crazy kids that always said from when they were little that they wanted to become a doctor. Some people I know have had impactful stories to happen to them or experiences where they were sick or a loved one was sick when they were growing up, and then they were kind of exposed to the healthcare field after that. But I, strangely enough, just don't have that story. I guess I would say that I've always wanted to become a doctor because when my mom was younger, she wanted to be a doctor, but she didn't end up going that route. She ended up being an educator, but she likes to say, if you ask her, that she passed down that idea to me from osmosis, from birth, basically. So it's just an idea that I've always had from growing up. You can ask all of my childhood friends. They're like, yep, Kim wanted to be a doctor, and that's what she did. So that is really what drove me as some, invisible force throughout life to become a physician. And now here I am.
Sure. That's awesome to have that focus from an early age. Was it the idea of the patient care that you embraced first, or the idea of the science behind the medicine that really grabbed you?
I think it was really the patient care experience. So where I'm from originally is Milwaukee, Wisconsin. And Milwaukee, when I was growing up, and I believe even still till today, has a very high rate of teen pregnancy. And coming from a single parent home, my mom always instilled in me to be careful about, becoming sexually active and experiences growing up. But I did notice that some of my childhood friends had babies at younger ages. So I originally started off wanting to be an OBGYN and affecting their experiences in healthcare and try to educate young women, especially young women of color, about their sexual health and actually having safe pregnancies. So that's where my drive came from. I really wanted to be hands-on, be a role model for my patients. It really was less of the science and the math part, because I really struggled with that, to be really honest with you. I had to put in a lot of hard work to get past those things. I really believe that it was the patients that drove me.
Oh, that's awesome to have that kind of motivation and really being connected with how you can help and coming from that single parent upbringing. How did that impact your experience in medical school and dealing with the internships and residencies and that lengthy and complicated and sleep deprived path that doctors generally have to go through?
I think it pushed me even further, or it gave me a desire to become a doctor even more, because of course, when you're in medical school, it's hard. I mean, you're just, especially your first and second years, you don't see patients very often. You are kind of in the books and doing biochemistry and anatomy and histology and all of these.
And I'm going to say, I think in those first or second years that you're not seeing patients very often, I think many of the patients are probably grateful for that.
Yes, absolutely. Because when you see a wide-eyed young medical student coming in with a short white coat, you're like, oh God, what's happening to me? So, because no one wants to be the guinea pig in the hospital.
Right.
But when I did get a chance to see patients, that pushed me even further because I was able to apply what I was learning in the classroom to an actual patient. And it's not just on a, piece of paper or on a book. In a book, it's something that I can actually apply and I can figure out like, oh, this is why I need to know this. This makes sense. And now I'll never forget it. Mm-hmm. So when I listen to a murmur online on a computer, trying to figure out, where is this murmur coming from? And then when I actually hear it on a patient after talking to them, I'm like, oh, wow, that makes perfect sense. So still my drive to actually touch people and impact people have been my drive throughout, more specifically medical school for sure.
Sure. And that definitely helps ground you and really connect you with connect back to your motivation as well. That's an important absolutely. Connection there. As you're going through all this, obviously, like you said, you're on the path to be an OBGYN and decided to make the shift over to emergency medicine. It's just a mind-boggling field to me. How did you make that choice?
Okay, so that's a fun story as well. I'll have to take you back just a little bit. So
awesome. I love going back.
Yes, let's go back. Let's go all the way back. Well, not to my birth, but let's go back to college. So like I said, I walked into college knowing that I wanted to be a physician. I was biology pre-med at Fisk University in Nashville, Tennessee. And I was around a bunch of other people that wanted to be doctors. But when it was time for me to take my MCAT, which is the medical college acceptance test, which everybody knows is a very difficult test, I didn't do well. And I didn't just do well once or twice. I didn't do well 3 times. And so that was a little bit disheartening for me, but I knew what my passion was going to be, which was becoming a physician. So I ended up going a slightly different route before I went to medical school. I actually got a master's degree in public health from the University of Florida, still keeping in mind that I was going to continue to reapply for medical school. So one summer, while I was in my graduate school program, I ended up going to Ecuador. And that was to prepare me to, for my medical school applications, to get some hands-on experience, get into clinics in Ecuador, learn some medical Spanish, really see the world a little bit. I had never really been outside the country before. So that was a lot of fun. So I went down to Ecuador for a maternal and child health rotation. So I was going to be working with OBGYNs, pediatricians. I was going to be working in family practice clinics. So all of those things kind of around women and children to expose me to that. Well, they put me on my very last week in Ecuador in accident and casualty. And I didn't know what that was. I asked the medical students. I asked the pre-med students. Nobody knew what accident and casualty was. So I'm irritated. And I'm like, well, I'm supposed to be doing OBGYN stuff. Like, I don't know. What is this? So I walk in and it's basically the ER in Ecuador. And so it's literally a room, a triage room where attending physician sits, and an attending is a supervising doctor, someone that's gone through medical school and residency and has passed all their required boards and they can practice independently. And so there's an attending physician sitting in the room, and basically patients are coming in one door and they're saying, this is why I'm here. I remember the first day, my attending let me have way too much leeway as a pre-medical student than I thought I should have. I was giving injections. I was learning how to start IVs. I was seeing kids. I was seeing women. I was seeing men, old people, young people, you name it.
A very different litigious culture.
Exactly. A completely different culture than what we experience in the United States, for sure. But it was the excitement of, wow, I literally don't know what's going to happen next. Like, is someone very sick going to come in? Is someone not going to come in? Am I going to see a man? Am I going to see a woman? Like, it just, that initial excitement and the fact that I got to do so much with my hands was mind-boggling to me. And so I only spent a few days in accident and casualty, but I was hooked. Like, after the first day, I'm like, wow, what is this? Is there a specialty that's similar to this in the United States? So I remember going to the internet cafe down the street from where I was staying, and I started going on Google and I was looking it up. Like, what is this? And I found out that it was emergency medicine. And after that, I have been hooked. And so that still is what drives me to practice emergency medicine today. I love being able to see people, all walks of life, all ages, sometimes not very often. I do deliver babies, so I still have that passion in me. I like delivering babies, but I don't prefer to deliver them in the emergency department. It's not really the best for babies. And sometimes I pronounce people. So I really get the chance to see someone get to see life from the beginning all the way to its end stages. I see people from, like I said, all walks of life. And that is why I truly love emergency medicine. I think that's what drives most of us. I still like doing lots of stuff with my hands. I can do procedures in the emergency department, all the way from pretty minor, like sutures or stapling someone's head together, to all the way to critical care procedures. And I love everything in between it. It's awesome.
I imagine that probably also feeds into your passion around public health and management and policy. That's sort of the business end of what happens in public health.
Absolutely. And I always say to people, kind of, how do I plan to bridge public health with emergency medicine? I don't think that I necessarily have to bridge it. Public health is emergency medicine, and emergency medicine is public health. We are the front door of the hospital. We're open 24/7, 365. We never turn anyone away. We literally are the safety net for everyone in the United States. So if you don't have health care, if you don't have a doctor, if you're uninsured, you can always come to the ER. That's not necessarily the best place for you, but if you need us, we're there for you. And so that is, in essence, public health as well. So
right. And somebody who doesn't have insurance, who has a stroke, is going to go through the ER and get their initial treatment, but they're not going to get their physical therapy or their occupational therapy or their speech therapy through that pathway.
Correct.
So I think obviously a lot of us survivors, we make our entry again through that front door of the hospital into the emergency department. And one of the things that's that, I remember from my own experience was going off the ambulance. We go into the doors and pause very briefly while they stick an IV thing in me and put the hospital bracelet on me. And then it's straight off to imaging, CT, and then off to the room in the ER where they do the other stuff. They were all ready for me as soon as I got there. And that was, maybe like a 4-minute ambulance ride. So right. Once the EMTs or 911 contacts the hospital, or that there is a potential stroke patient coming in, what's happening in the ER at that point before the patient even gets there?
Right, absolutely. You actually kind of nailed it. So once we hear that a possible stroke patient is coming in, we mobilize. We get ourselves going. So the ER doctor on duty comes. There's a nurse that gets assigned. Sometimes there's a tech or a paramedic that's there for you. Depending on the capability of your hospital, you may have a pharmacist, an ER pharmacist that's there kind of to see if they can assist in any way. But there is basically a clarion call to, hey, heads up, we got to rapidly assess this person. We need to get them to imaging and get them in and out. So it's basically, like you said, like you think it happens. It's a big call. Our radiology staff is aware, so that if someone else is emergent, or not as emergent, I would say, about to get an image, like a CT scan of their stomach or their head or whatever, we can push that person back for a few minutes to make sure that the stroke patient, the possible stroke patient, will come in and get imaging as fast as possible, because time is tissue, time is brain. And so we don't want to delay you getting your imaging and us having life-saving measures delivered to you as soon as we possibly can.
You know, you mentioned a specialty I had never actually heard of, but makes sense. The idea of an ER pharmacist as a specialty of somebody who is specialized in that. And I suppose when you start looking at things like TPA, that's becomes a really important role.
Absolutely. If no one knows, I absolutely am a huge advocate for pharmacists being in the ER. Where I trained for residency, we had ER pharmacists, and we also had an emergency medicine pharmacy residency for pharmacists that just got out of pharmacy school, and they can train in emergency medicine as well. But they are absolutely fantastic resources for us as physicians to help us stay abreast of the most important research around medications and critical care. And also they are a lot of times the ones that help us mix TPA for the patients and give it to the nurses and help nurses to figure out how to program drips and how to get the medications to patients very safely. They're an absolutely amazing resource for any emergency department. And I'm so glad that I've had an opportunity to train with some of the best ER pharmacists in the world, honestly.
Oh, that's fantastic. I think most people outside the medical field, our perception of pharmacists is that it's not quite the same specialized role. They're the people that takes, medicines out of the bulk bottle and put it into the little bottle and then read the list of side effects when you have a consult. But there's so, their knowledge and the research they're doing to stay on top of things and to support the doctors is just so much bigger than most people realize.
And I thought the same thing as well. Once upon a time, before I was a physician, I was also a pharmacy tech at Walgreens, if I can say a brand name on your show. But it was like, that's what I thought pharmacists did. They just counted your pills and verified everything and wore a white coat and asked if you had any questions. I had absolutely no idea about the level of education and enthusiasm they have around certain topics. And there are, like I said, pharmacists around in emergency medicine. There's pharmacists that do critical care. There's special pharmacists for pediatrics. There's a lot of different ways that pharmacists are very impactful to the healthcare industry, and they don't get enough shine, honestly.
Yeah.
I'm very happy to work with them.
Absolutely. So, obviously you've got that whole clarion call and that whole system that comes into place as soon as we know a stroke patient is coming into the ER. But I imagine a lot of times you don't know. Either the patient hasn't really been assessed well, or they show up in their car because a friend drove them, or unfortunately sometimes, they drove themselves and just sort of show up. So how often do you have stroke patients that are just coming in without that level of warning?
It happens all the time. It happens probably more, I would say, than EMS bringing in stroke patients. So there's still the same thing that happens if you walk into the front door having stroke-like symptoms. There's still a protocol in place where we are notified immediately that we need to rapidly assess the patient. So I guess backtracking a little bit, when you walk into the ER, the first person you're going to see is going to be a registration person, and they're not medical at all. They're just a, secretary, and they're basically in charge of taking your name, your insurance, all of your information, and basically a very brief of why you're here. Does your head hurt? Does your stomach hurt? Or you're weak in one arm? Something.
Are you leaving bodily fluids on the floor as you walk in?
Exactly. Oh, I'm leaking bodily fluids. I need help. Help me. They are trained to kind of at least pay attention to people that look sick. And you'd be surprised how well they can do that. And they will let a triage nurse, so a nurse that sits up front to help intake you, to let them know immediately that you need help. And so sometimes they can help do that. The registration can help you get escalated, or sometimes that might be missed. And it's the triage nurse when they pull you back in and ask you questions and take your initial vitals. So either way, there is still the system in place where someone will let a physician know, will let the ER doc know immediately, hey, we need you to come here. This patient may have a stroke. And so where I did residency, it was, I need a doctor to room wherever, or a doctor to triage, please. And sometimes you didn't know what it was for. But lots of times it was strokes, or suspected strokes, but a lot of times it could be any number of things. So there are still ways to get the ER doc in the room immediately and let them know what's happening.
That's certainly fortunate. Obviously, that does add extra time, and with time being tissue, 911 or 999 in other countries or wherever is still, the best way to get there if stroke is a possibility. But when you are assessing folks for possible stroke in the ER, are you, most of our listeners are familiar with FAST and BFAST now, but is that what you're looking for, or is there something else that you look for as a physician when trying to figure out, is this person having a stroke?
FAST is definitely one of the things that we look for immediately, because FAST, if you use that acronym, can help us find large vessel occlusions like an MCA or an ACA stroke, or sometimes even a posterior circulation stroke. So, yes, so we do that. But I am been trained, luckily, to do a pretty fast and thorough exam of kind of all of your cranial nerves and everything else. So I do a full neuro exam in probably about a minute or two.
Wow.
So I'm looking for anything that triggers me to think that there's something that's stroke. So I don't wait very long. I ask for a blood pressure and I ask for a blood glucose. So just pricking your finger to make sure that you're not having low blood sugar, because if you're diabetic or a new diabetic, your sugar can be low, and that can also be a stroke mimic. So I'm lightning fast on my assessment. If I have any question and your blood pressure is within a certain range and your sugar is normal, I'm sending you to CT, and I'm calling the neurologist to meet me at your bedside as soon as I possibly can. So we're looking for that, but we're also, like I said, I just mentioned stroke mimics. So there's other things that can be happening to you. Like I said, having low blood sugar to cause you to have stroke-like symptoms. Sepsis, I don't know if your listeners know anything about sepsis, but that is a life-threatening infection that can cause confusion or weakness in someone that's previously had a stroke, or maybe they're chronically debilitated, or it could just be a presentation. It wouldn't be necessarily like you would lose function of an arm or a leg or anything like that from sepsis. But if you're just kind of like generally weak and confused, then that could be a cause of some confusion. Also, if someone comes in with low blood pressure, I would be less likely to think that they're having a stroke. It's probably because your brain isn't being perfused because you don't have enough volume going to your brain or blood flowing to your brain. So if you come in with low blood pressure and you're having stroke-like symptoms, I'm concerned, are you bleeding from somewhere? Are you severely dehydrated? Are you septic, like I referred to before? So anything else that it could be that I can try to narrow down with vital signs, my physical exam, and a blood sugar, I'm doing that in the first 3 to 5 minutes of seeing you. And it's a lot of things that are firing in my brain that I'm not necessarily saying to the patient. Sometimes it's kind of just all synapses that are just going on each other. And could this be this? Could this be that? So that's really what's happening. Just making sure that I'm not missing anything else that it could be before I rush off and have you get CTs and CT angiographies and have neurologists and neurosurgeons at your bedside.
Right. We want to get the right specialist there as quickly as possible.
Exactly.
What I think is interesting is how from just a small number of initial data points, blood pressure, blood sugar, things like that, is being able to eliminate so many possible diagnoses and open up a whole bunch of other ones and then narrow it down very quickly from just a few data points. You don't need like 500 different data points to figure out the right path to take this patient down.
Exactly. Absolutely. I think since we've seen so much more stroke in our country and we've done a lot more research on it, we realize that we really just need to narrow it down to the bare bones to make sure that if this patient is actually having a stroke, we don't need a lot of fluff to really get to the nitty gritty, because like, again, time is brain, time is tissue. And so I don't want to have a 18-point checklist that I need to go through before I can say, yes, you're probably having a stroke. Let's go to CT scan. That's time that's wasted from your recovery, from your diagnosis, from your treatment, most importantly. So it's really cool that it's only a couple of different things that I actually super need. And people would just argue that you need a CT of your head and a blood glucose. So I would add that in there too, but that's what we're trying to get you towards. So
right, absolutely. When it's interesting that the CT is, I know in my case of my stroke, it didn't show up on the CT. It showed up on the MRI, but not the CT. Mm-hmm. So it's interesting how there's these different limitations and opportunities with the different imaging technologies.
Mm-hmm. So it sounds like you went to was it a comprehensive stroke center? Yeah. Do you know anything about those?
Yeah, it was Seattle's Comprehensive Stroke Center. So they have the neurologists on call 24/7. They can do TPA and thrombectomy. In my case, right. I woke up with symptoms, so I was immediately outside the window of TPA. Right. I was fortunate. I had some really awesome care at that hospital. And I've been told if you got to have a stroke in the United States, Seattle is one of the best places to do it.
Wow. Well, I would echo that. If you're in the South and unfortunately suffering from a stroke, if you're in Memphis, Tennessee, Methodist University Hospital, it's the best place to have one. We're also a comprehensive stroke center. We have some of the best neurologists and neurosurgeons in the world. And same thing down here in Memphis. We have the ability to do thrombectomy, TPA. Our hospital, which is this is the hospital that I did my residency in, is we actually TPA'd the most strokes in the world in 2014. So we are very, very comfortable with taking care of stroke patients. So if you unfortunately are having a stroke, try to get them to take you to Methodist University, which they usually will. So.
Absolutely. That's fantastic. And the difference TPA makes in patients' recovery is just striking. The survivors I talk with who've had, similar strokes to mine, but were within the window are back and, nearly fully recovered in a week or so, versus the deficits I ended up with. So it's really amazing. It's why time is so important, why you should never try to just sleep off these symptoms, because it's not going to help you.
Exactly. And unfortunately, I have had patients say that, well, I thought it was going to go away. I'm like, ooh, if I was waking up and I couldn't speak and I couldn't move my arm, I'm not going to try to sleep that off. But it's all about education around this. And again, this is why I'm so glad that you have this podcast, because it gives people, not just survivors, but other just general public, the information that they need to kind of be aware and make sure that they are getting the right care as fast as possible.
Absolutely. That's why I do it. That's why it's so important to share stories and give everybody an opportunity to talk about their story and what they can learn from it. So, as folks come into the healthcare field for the first time as patients, they come into the ER, they're panicking, they're in crisis of some sort. What do you wish more patients or caregivers knew or said or did when they arrive?
I totally depend on friends and loved ones to supply as much information as possible when the patient is in distress. So, especially around stroke care, and if you accompany a loved one to the emergency department when they are possibly having a stroke, whether you drove them or you rode an ambulance with them, hopefully you rode an ambulance with them, I need as much information as possible. But the main question that you will guaranteed be asked is, when was he or she last normal? So when we ask a family member that, we need to establish a timeline to when you started having your symptoms, because that's definitely important in treating stroke. Again, time is tissue, time is brain. And so if you were last normal last night at 11 o'clock p.m. and you're coming to me at 10 o'clock in the morning with these symptoms, then you're probably outside of the TPA window, as you've discussed on your show multiple times. So if you can help us establish a timeline by giving us information about when they were last normal, that is very, very helpful to not only me as a physician, but your loved one as well. Also, I would say if you know anything, absolutely anything about their medical history, please share it with us. If you know what medications they're on, if you know why they're taking these medicines, if more specifically, if your loved one is possibly having a stroke, if you know if they're on any blood thinners like aspirin or Plavix or Xarelto or Eliquis, those are all things that are very important for us to know and for you to share. So that also can kind of help us weigh the risk versus benefits of us giving TPA to your loved one or not. Also, letting us know what they were like before we see them in the emergency department. Fortunately, or maybe unfortunately, I've never met you before. So I don't know how you live your life and how you go about your daily living. Do you use a cane? Do you use a walker? Do you use a wheelchair? Are you bedbound? Are you completely normal and don't need anything? Or I shouldn't say normal, but are you completely unassisted and don't need any sort of assistance whatsoever to help you ambulate? Those are all things that I need to know. So I can determine what's different today and kind of sort out in my mind, okay, is this just kind of a worsening of a previous symptom or is this a brand new symptom? I especially, like I said, need to know if the patient has had a stroke before and what problems or what issues you have left over from it. So are you already weak in your left leg? Do you already have some difficulty speaking? Do you have blindness in one eye? So when I'm assessing you, I know what is kind of old and they'll help me figure out what's new. So family members and friends give us a breadth of information to help us to figure out what's going on with you. And honestly, I would rather a patient's family member be over helpful than under helpful, because the more information that I can gather just by talking to you, that's less time that I need to spend trying to see if you've been in the ER before, looking up your hospital stays, all kinds of other things.
And I suppose one of the things that could be really helpful in that area too is something we didn't have as much of 10 years ago, and that's things like cell phone video and pictures. If you've got video of your partner or whomever you've brought in who may be having a stroke, video on your phone from a week ago or 5 days ago that can show what they were when they were quote unquote normal pre-event is probably super valuable as well, because it sort of takes out some of the interpretation.
Absolutely. I didn't even think about that. That is very true. If I can see them, in their regular element beforehand and then kind of comparing them to where they are now, that's absolutely helpful. And along the same vein, if you have a picture of that person pre the emergency department, that can be helpful in me determining whether they're having a facial droop or anything like that might be a little bit subtle that I might not necessarily notice, but you have because you've seen this person over a longer period of time. Those are great tips.
Absolutely. And if they happen to be a podcast host in the future, that's always great to have those additional voice samples as well.
Yes, absolutely.
So one other thing you mentioned there, and I want to touch on, is we talked about that window for TPA, and in general, it's in that neighborhood of 3 to 4.5 hours, depending on a lot of very specific circumstances. But there may be a temptation where this is this medicine that can have this tremendous impact and prevent this long-term disability. There may be a temptation to sort of fudge the time frame on the part of the person having the stroke or their caregiver to try and get them into that window. What's sort of the risk of giving TPA outside of that window?
Wow, that's a great question. So yes, the 4.5 hour time period is what's acceptable now. Some people are even pushing it to the 6 hour time mark. And so the longer that it has been from the onset of symptoms to you receiving TPA, the more risk there is for you to bleed. So to be very specific about what TPA is, TPA is a clot busting medicine. What it does is it thins your blood very rapidly, and it also eats up any clots that are going on in your body. More specifically, your brain. Also, TPA is used to treat pulmonary embolism, which is blood clot in your lungs, and also coronary artery disease or stroke. Heart attacks, more specifically as well, if you cannot get to a cath lab while you're having a heart attack. So it's used for that as well. But as it breaks up clots, it actually, of course, makes you more likely to bleed. So you can have some life-threatening bleeding from your stroke. If it's ischemic, can become hemorrhagic. So you can go from having a clot to having a bleeding stroke. You can bleed in your GI tract, meaning anywhere from your mouth to your bottom. You can start bleeding from there. There's all kinds of different ways that you can bleed, and that is dangerous as well, because it's hard for us to reverse the medication when we're trying to treat something and you have something brand new. So if we try to make sure that we are in the right time window for you, because we want to make sure that you get the right treatment, which is TPA a lot of times, but we also want to make sure we're giving it to you as safely as possible. There's been a new study out, not about TPA, but about mechanical thrombectomy, which we talked about briefly. And so basically that's when they go in and basically pull out the clot in your brain. And so if you're having a large vessel occlusion, meaning like a middle cerebral artery stroke, an internal carotid stroke, an anterior circulation stroke, then they can go in and safely retrieve those up to 24 hours after you having those stroke symptoms. So that may be an option for you if you're the right candidate, and that could be a lot safer than you getting TPA out of the window. So we just want to make sure that in everything that we're doing as physicians and healthcare professionals, that we're doing things as safely as possible, but again, making sure that you get the best care as possible.
Absolutely. And after that window's expired anyway, the benefit of busting up that clot, a lot of those cells are already dead anyway. So there's certainly that. The interesting, the thrombectomy 24-hour window opened up. I think that was came out in January, and that was one of those things where I read the news, and that was very much one of those, well, now you tell us stories. They couldn't come up with this 7 months ago, and that would have been actually useful for me. But
yes, exactly. We said that in emergency medicine as well. It's just like, okay, well, we could have been sending so many people up to cath lab to try to make sure they get safe. But I'm glad that the information is coming out. Emergency physicians have been educated on this. And so if you are someone that comes to a hospital that is not necessarily a comprehensive stroke center, then hopefully you have those symptoms and you are eligible for thrombectomy, that you'll be able to get to a comprehensive stroke center where they can assess you and hopefully give you that treatment with the thrombectomy.
So one of the things about, like say, you've done, at your facility, they've done more TPA than any other hospital, and that's awesome. It also points to one of the other challenges in Tennessee and a number of states in the South, and that's the more opportunity to do more TPA, because there is so much more stroke happening in the stroke belt in the South and Southeastern United States. Why do you think Tennessee has such a high incidence of stroke?
Well, Bill, unfortunately, Tennessee, even though it's where I call home now, it has a lot of issues. It has a lot of issues around poverty. It has issues with access to care in not just urban populations, but also rural populations in Appalachia. There's a high obesity rate here, and there's a lot of people that are still uninsured or underinsured. So those are all barriers for patients to seeking medical care and understanding their health and their bodies and how stroke works. And stroke prevention is not just, okay, take your blood pressure medicine. It's how can I get access to healthy foods so that I can eat my fruits and vegetables, so I can lose the weight, so that I'm not at higher risk for diabetes and high blood pressure and stroke and heart attack. So it's multi-layered, to be very honest with you. And I hate to say that because it's always like, oh, it's so many different things, but unfortunately it really is. And it all ties in together in why Tennessee has such a high stroke rate.
And a lot of those things that contribute to the high stroke rate directly probably are also indirectly contributing to it as well, with, obesity that contributes to sleep apnea, with poverty and access issues that contributes to everything from the meth crisis in the country, and especially in rural communities, to the food deserts we find in urban communities. That
absolutely
all further builds on that.
Also, the opioid epidemic is hitting us just as hard as it's hitting everyone else, especially in Appalachia, where I'm practicing here in the Memphis area. There are a lot of patients that not only do heroin, but do cocaine as well, which can cause not necessarily ischemic strokes, but hemorrhagic strokes. So there's a lot of patients here that are pretty young, meaning like 30s, like our age, 30s, 40s, that have had hemorrhagic strokes because of cocaine abuse. It's a lot of different issues that are compounding, like you said, to make stroke a big problem here in Tennessee.
So putting on your public health management hat, I mean, what can be done to start addressing that? And I know that's a big question.
It is a big question. You're absolutely right. It is a big question. So you're right. Coming from my public health management and policy hat, I'm going to go with the policy answer first. I think it starts with our legislature and making sure that we are doing statewide legislation that helps patients. First of all, making sure that patients have healthcare coverage. Number one, that's the big thing. Number two, making sure that we are having a decreased amount of food deserts, like you brought up before, in our cities. Making sure that we have programs in place that incentivize physicians and healthcare professionals going to underserved areas in Appalachia, in rural communities, in urban communities even, to make sure that people have access to care. It's making sure that our schools are good and have strong performance so that our children know how to read and understand and digest information, and understand and digest information about their health as well. It's also on us as physicians, and I lump myself in with primary care a lot of times because, like I said, we are the front door of the hospital. We have to do better about educating our patients and using the right language to make sure people truly understand what's going on with their bodies. I try to take a moment every time that I'm with a patient in the ER, whether I'm going to be admitting them or discharging them, whatever, and try to educate them a little bit about what's going on with their body. There's so many people that come in to ERs that just don't know. They have a list of medicines that they're taking because somebody somewhere decided that they needed to be on these medicines, but a lot of times they don't understand why they're taking them, what they're for, why they shouldn't stop taking them abruptly. So there's a lot of education that primary care and emergency physicians, even though we're very busy, need to do to make sure that patients understand what's going on. So I would just push policy and one-on-one education about health in general to help impact Tennessee and their stroke rate.
One of the things that's become more and more clear to me is that we think of stroke itself as a condition, as a disease, as, whatever. And sure, it is a major condition and a major thing to treat, but really stroke is a symptom of something else that's going on, whether that's going to be high blood pressure, coronary artery disease, vertebral artery dissections, diabetes, or a symptom of the other social problems that we have, the poverty, the drug addiction, the challenges around food and diet and opportunity around the country.
It is a symptom, and unfortunately, and not to get too political, but I'm saddened at the repealing slowly of what Obama tried to do with his healthcare policy while he was in office, because so many of the things, number one, mandating that everyone is covered. That is not necessarily just to be a financial burden, but if you have access to a physician or to the healthcare industry in and of itself, that can prevent so many different issues down the road. If you have someone that you can go to on a regular basis, and you're not worried about, well, I'm not insured and how much is this going to cost and all these other things, that can unlock the door to so many different possibilities. So the fact that we have repealed the mandate is honestly really disheartening to me, because that's another reason why so many people, mainly in my generation, I call myself an old millennial, don't have primary care physicians, because it's just like, why do I need to? I'm young, I'm healthy, there's nothing wrong with me, I'm living my life, there's no big deal. But you still need someone to talk to, because right around the corner, you never know what's going to happen to you, and you don't know what you're at risk for. So if you don't have someone that you can talk to about issues that may pop up and screening you for heart disease, diabetes, strokes, heart attacks, things like that, then it's just only going to exacerbate the problem.
And especially since things like high blood pressure, they don't hurt. You're not going to feel any pain from the high blood pressure that is damaging the arteries and ultimately leading to stroke.
Exactly. And that's why I tell patients all the time. It's just like, yeah, you cannot take your insulin. You can not take your metformin. It's not going to hurt you today, tomorrow. Might not even hurt you until 5 months down the road, but you will feel the impact of it eventually. And because, like I say, it's like you said, it's silent. Like it doesn't hurt until something happens, like you're having chest pain and you're found out that you're having a heart attack or congestive heart failure, or you're having a head bleed or a stroke. That's when you find out all of these things. But you have to stay on top of yourself and make wise choices all along, so to hopefully prevent those things.
When you look at what's happening politically, you talk about those mandates. The other thing that I'm getting more and more concerned about now too is obviously the questions around pre-existing conditions and the changes they're talking about making to the Americans with Disabilities Act, which, after having gone through all this and navigating life with physical disabilities, becomes more and more of a concern in what's going to happen going forward.
Absolutely. That's very scary. And unfortunately, that's another population, yourself included, that may be disadvantaged with the new changes. So I'm just hoping that our government kind of starts to understand the impact of those things. And I charge myself as a physician and my fellow physicians and healthcare professionals that a lot of times our legislators don't know about the long-term down the road impacts. And so it's my job to help be your advocate as a stroke survivor to say, hey, no, you see this as a line item on your budget, but this is going to impact my patients, and this is going to impact your friends and family down the road in X way. And really making sure that we as physicians are using our influence to speak to our local, national, and federal legislators to say, no, this is what we want. This is what we need as Americans, and helping each other move forward in a more positive way.
Absolutely. And there's certainly an element of healthcare that is, regardless of your of whatever position you find yourself with, is going to be about advocacy and advocating for people, for colleagues, for friends, for relatives, for family, and for others that you work with. And in terms of other folks that you work with, the way you and I connected was actually through an organization called Women in White Coats. Can you talk a little bit about that group that you're working with?
Yes, absolutely. So Women in White Coats is a group of fantastic women across the healthcare industry, physicians, nurses, nurse practitioners, physician's assistants, you name it, that have come together to tell their stories in healthcare. We talk about anything from maternity care to maternity leave. We talk about career choices. We talk about breastfeeding. We talk about pretty much anything that would impact women in healthcare, and not necessarily just women in healthcare, kind of women or healthcare in general. We talk about all those topics. So in May 2018, there was a book released called The Chronicles of Women in White Coats. And one of my good friends and the person who connected us, Dr. Amber Robbins, she wrote that book with a group of other fantastic physicians across specialties. And that was a hugely successful book. And so there were more and more female physicians and healthcare professionals that reached out to her and said, hey, we want to tell our stories too. Can I be in the next book? But they had such a huge response that they decided to do a blog instead. So if you go to www.womeninwhitecoats.com, that is where you can read all kinds of stories about career, lifestyle, dating, education, all kinds of things about women in healthcare, and get a great feel for what we're doing over there.
Awesome. So it's really about supporting women who are working in this field, whether that's going to be in their career advancement, their personal advancement, and just living better lives while taking care of their patients.
Absolutely. That's it. You said it way more succinctly than I did.
Awesome. Well, we'll definitely get those links up in the show notes. And that brings us to our hack of the week. Share everything.
If you have a disability and when you come into the emergency department, I totally depend on you to tell me what's normal for you, what's abnormal for you. So just being clear with not just me as your physician, but your nurse. If there's a tech taking care of you, everyone in the emergency department wants to help you and meet you where you are. So if there are some things that make you feel uncomfortable, or that is abnormal for you, please let us know. We are always here, like I said, just to help you. And despite that, I just tell all patients to just be very open about where they are in their disability, what they can and can't do. And so, like I said, we can meet you right where you are.
Awesome. So if folks want to know more about you and what you're up to, where should they go?
So I have a website that I am finishing up, and by the time this podcast comes out, it should be done. You can find me at www.drkimberlybrownmd.com. If you want to send me an email, you can send me an email at info@drkimberlybrownmd.com. I'm also on Instagram, Facebook, Twitter, and all of those are at Dr. Kimberly B. And my Twitter handle is at Dr. Kimberly B _. and I'll be happy to talk to you guys.
Fantastic. And we'll have all those links in the show notes as well. So you can definitely go ahead and check those out. By the way, I like that action shot of you on the website, sitting at that cafe with your laptop.
Thank you. It was a lot going on that day. There were trains and trolleys and people were staring at me. I'm like, oh my goodness, people think I'm crazy sitting in here with my scrubs typing on a computer. But I think it turned out to be a great shot. A really great photographer.
Awesome. Well, Kimberly, thank you so much for joining us this week. This has been fantastic.
Thank you so much, Bill, for having me. I really enjoyed talking to you.
Be sure to check out strokecast.com/Kimberly for all those links and more. And now for our special treat. November is National Caregivers Month. These, of course, are the people who make a huge difference in our lives. Nobody chooses to be a caregiver. It's sort of the role that folks find themselves thrust into when a loved one or family member has a stroke or starts succumbing to dementia or Alzheimer's or all sorts of other conditions. It's important to recognize and thank the caregivers in our lives for their support. Of course, one way to support caregivers is to read Dr. Kate Lorig's book, Building Better Caregivers. It can be a great gift for the caregivers in your life. I talked with the author back in episode 19 at strokecast.com/Kate, so go ahead and check that out. Larry Benitez is one of my colleagues from a professional networking group. He's also a banjo player who volunteers at the Old Friends Club in the Seattle area. The Old Friends Club supports folks with Alzheimer's and dementia. Larry recently recorded a song dedicated to caregivers. You can find it on YouTube by going to strokecast.com/Larry's song. You can also learn more about it by going to strokecast.com/Larry's story. Or just head on over to strokecast.com/Kimberly for all the links we talked about today. And now, here's Every Branch and Leaf by Larry Benitez.
Friendship is a sheltering tree. The shade here is for both you and me. It's quite a relief knowing every branch and leaf is taking care of sheltering me. This sheltering tree is keeping me dry. It shields me as the rain goes by. It's quite a relief knowing every branch and leaf is protecting me and keeping me dry. Friendship is a sheltering tree. The shade here is for both you and me. It's quite a relief knowing every branch and leaf is taking care of sheltering me. This shading tree is keeping me cool. The hot sun can sometimes be cruel. It's quite a relief knowing every branch and leaf is offering shade that's keeping me cool. Friendship is a sheltering tree. The shade here is for both you and me. It's quite a relief knowing every branch and leaf is taking care of sheltering me. This caring tree is warm in my heart. It brings friends from both near and far. It's quite a relief knowing every branch and leaf is cultivating joy from the heart. Friendship is a sheltering tree. The shade here is for both you and me. It's quite a relief knowing every branch and leaf is taking care of sheltering me.
That's it for this week. Be sure to check out drkimberlybrownmd.com and connect with Dr. Brown on social media. You can also head on over to strokecast.com/Kim for that and all the links we talked about. Explore the Chronicles of Women in White Coats and check out their programs. Be sure to comment on Larry's video on YouTube. Share this episode with a friend, colleague, relative, ER denizen, or banjo player by sending them the link to strokecast.com/Kimberly. And, of course, as always, don't get best, get better. Thanks a lot. I'm Bill Monroe, and I'll talk to you next week.
The Strokecast, Bill Monroe, and Bill's guests provide general information and entertainment, not medical advice. Please do not make any changes to your treatment plan or the execution of your treatment plan without first consulting your personal doctor or medical team. The Strokecast is a proud production of the Currently Speaking Podcast Network.